Well, it's absolutely wonderful to be here at this kickoff meeting of a new partnership between At the Limits and Latin America. I think that the hospitality that we've all enjoyed here, the scientific quality, the organization has been a real testament to this union of our local hosts and the wonderful staff and leadership of At the Limits. So it's really heartwarming for me to see us add a new continent to the At the Limits series. These are my competing interests. I do not accept any personal compensation from any company that makes a device or a drug that I can write a prescription for. So, we've made very gratifying progress in inroads against cardiovascular risk management. You just heard a magistral talk that summarizes advances, some of them very recent, some of them nascent, in the management of heart failure. But I can answer the question of the title of my talk, Have We Reached the Limits with Atheroma, with one word, and that is no. So I could stop now, and we could have coffee early. But the battle is joined. We've started the battle, but it's not yet won. What are some of the data that support that contention, that we must not relax our guard against this enemy? Well, if we look in recent clinical trials with the latest of P2Y12 inhibitors, or the latest of the non-vitamin K oral anticoagulants, we see that in patients after an acute coronary syndrome have about a 10% recurrence rate in the first year. Now, this is in clinical trials. And the care of these patients never gets better than in the environment of a clinical trial. So on Monday morning, day after tomorrow, I'm going to start 2 weeks of clinical call in the cardiology service at the Brigham. And almost all of the patients that I will be taking care of, as the patients that you all take care of, wouldn't meet the admission criteria for most of those rarefied clinical trials that have the big funnel from the screening through to the inclusion, because they have comorbidities. And John just showed us the face of heart failure with 2 columns of comorbidities. And that's the real world in which we practice. Now, if we look at the Swedish database, where they have a wonderful way, we've already heard about at this meeting, of interrogating the entire country, and we look at the patients that look more like the patients that I will be seeing on Monday and that you all take care of in your practices, instead of a 20%, 10% increase in recurrent events, it's actually about 30% will have recurrent events in the first year. So the battle is joined, but it is not yet won. So how do we address that residual risk? I like to think of the different categories where we can make further progress against atheroma and atherosclerotic cardiovascular disease in different baskets of risk. You will notice that the coagulation part is not here. That's because I don't have a biomarker that allows me to do a simple measurement like the troponin for the kidney we were talking about yesterday, and say someone has residual thrombotic risk. And also, we're plumbing the depths of bleeding as we stack on antiplatelet and anticoagulant agents in our patients. But I'd just like to briefly deal with each of these baskets of residual risk. And let's start with LDL. We're going to hear about that in detail later. But I'd like to argue with you that we have plumbed the depths of LDL. That LDL management with our statins, with the cholesterol absorption inhibitors, and now with the PCSK9 agents, and even the newer agents that inhibit PCSK9 transcription, that the battle against LDL is won. We can drive the LDL into the basement, as you see here, from the Fourier trial, and also we saw it in Odyssey. Now, this is a slide that was lent to me by our colleague, Bob Giuliano, and it shows the outcomes as we push the cholesterol, LDL cholesterol, even lower and lower. And as we get to below 20 milligrams per deciliter, we have even greater efficacy. But within the confines of the time of exposure in the Fourier trial, the red hatches here show you the unfinished work that we have. Now, clearly, if we were able to keep the LDL down from birth as John Deanfield was talking, with early intervention, that we would be able to erase some of this residual lipid risk. But for most of our patients, it's too late for instituting primordial prevention. So have we reached the limits of lipid lowering? Well, we're about to hear about that. So I'm not going to discuss that any further. Now, what about glycemic risk? Well, we've just had a wonderful review of the SGLT2. We heard yesterday about the GLP-1 agonists as well as the SGLT2 inhibitors. And this is a very exciting a very exciting era as well, because we are really achieving a new mastery over not just glycemic risk, but the risk of cardiovascular events in our diabetic population. And so we heard about that yesterday from Mansour Hussain. So what happened to HDL as a target? And I'm going to deal with that only indirectly, because you're going to ask André in a little bit about what happened to HDL. So I would like to go to the other side of the teeter-totter of dyslipidemia. As you know, triglycerides and HDL tend to vary inversely. So when we have a low HDL, we also have a high triglycerides. And for generations, we've been adjusting the triglycerides in our observational epidemiologic studies for HDL, because we've been so convinced that HDL is a protective factor. So walk through these data from the Emerging Risk Factors collaboration with me. Now, what you see here is a very nice relationship between triglycerides and hazard ratio for first incident coronary heart disease. If we adjust for age and sex, we see this very steep slope in the black boxes. If we further adjust for non-lipid risk factors, we still have quite a slope. But if we adjust for non-HDL cholesterol and HDL cholesterol, because we believe that HDL is protective, this is very flat. It's flat as a pancake. So what's the flaw? Well, when we adjust for non-HDL cholesterol, we're actually adjusting for triglyceride-rich lipoproteins. Okay? So this captures triglyceride-rich lipoproteins, and if you adjust a risk factor for itself, clearly you attenuate its risk. So this is, I think, the fallacy that we've been laboring under for a generation, where we discarded triglycerides because once we adjust for HDL or other factors, that it attenuates the risk. The reason that I've had to revise my own view of the causality of triglyceride-rich lipoproteins in cardiovascular disease, and atheroma in particular, is because of the very strong human genetic evidence that has been snowballing over the last few years. Here is a scary alphabet soup, okay, of different genes that can contribute to the regulation of triglycerides and that have been associated with hard cardiovascular outcomes in the most recent series of human genetic studies. Now, I'm going to save you the trouble of reading all these papers and understanding this alphabet soup by making it very simple. Most of these genetically validated regulators of triglyceride-rich lipoproteins work through this enzyme of lipoprotein lipase. Things that inhibit lipoprotein lipase will raise the levels of triglyceride-rich lipoproteins, and things that will activate this enzyme will speed the trimming of the triglycerides off of these particles and pushing towards LDL, which we know how to deal with. So here is my comic book approach to all of those papers that I think that I haven't read them all, and I don't think that you need to read them all either. I see that there are 3 devils that inhibit lipoprotein lipase and will raise triglyceride-rich lipoproteins. And there's one angel, apolipoprotein 5, where the human genetic evidence and the experimental preclinical evidence all lines up very well to say that it is protective. So we have this real avalanche of new data that suggests that triglyceride-rich lipoproteins are causal. I'll just parenthetically say it's not the triglycerides that are causing the trouble. It turns out, and Borja Nordesgaard has been a leader in this area, that it is the LDL, it's the cholesterol in the triglyceride-rich lipoproteins that's delivered through a mechanism beyond the LDL receptor that causes the mischief due to triglyceride-rich lipoproteins, and that LDL is not very pro-inflammatory, to anticipate my next topic, but actually the triglyceride-rich lipoproteins are very, very much more inflammatory than LDL, and part of that is due to apolipoprotein C3. So Andre will have his chance to tell you about the functions of HDL, which you don't capture with the lab slip measurement. But I would like to say in this teeter-totter between triglycerides and HDL that we may have bet on the wrong side of this dyad for a generation, and that in fact we should pay more attention to the triglyceride-rich lipoproteins as causal agents. But what do we do about it? Okay. Well, we have a number of cardiovascular outcome trials that have attacked patients with hypertriglyceridemia. We have one which is reported, Reduce It, and since you already know the results of this study with eicosapentaenoic acid ethyl esters, I'm just going to summarize it briefly. We have Strength, which is looking at a mixture of eicosapentaenoic and docosahexaenoic acids, fish oil, omega-3 fatty acids. That trial is enrolled and will be reporting maybe not until year after next. And then I'd like to introduce you, if you haven't heard of it, to another trial called Prominent that is using a new selective PPAR alpha modulator. So Reduce It, I think you all are familiar with this trial because it was presented by our colleague Deepak Bhatt in November at the AHA. And we saw a remarkable over 25% reduction in the primary endpoint by giving a high dose, 4 grams a day, of this highly purified pharmaceutical-grade eicosapentaenoic acid. Now, what about the fibrates? Okay. The approval for the fibrates for atherosclerosis has been withdrawn by our US Federal Food and Drug Administration because the classical gemfibrozil, the classical fibrate, is unsafe to combine with statins. And although in the pre-statin era, there were statistically significant reductions in events and winning on the primary endpoint, we cannot use gemfibrozil in our current practice, given the strength of the evidence that statins should be at the base of our lipid management. And unfortunately, using fenofibrate, which is the one that's left standing available to us in the US for very high triglycerides to prevent pancreatitis, no longer approved for management of triglycerides, the studies missed their primary endpoint. But if you look at the patients that entered with hypertriglyceridemia, you see that these subgroup analyses, mostly post hoc, except in ACCORD, showed a positive endpoint. So those were very hypothesis-generating exploratory analyses, and together with Paul Ridker and Aruda Pranad, we are conducting a study with a novel selective PPAR alpha agonist known as pemafibrate that handsomely reduces the things that we think are bad in triglyceride-rich lipoproteins and has better safety signals, at least with the exposure that's been looked at so far, in terms of the creatinine, in terms of the liver function. So there is a large-scale trial known as Prominent, which is underway, supported by the Kowa Pharmaceutical Company. This is the design of the study, and very importantly, it's enrolling the patients that in the subgroup analyses looked like they might benefit from triglyceride lowering. I would say that the fish oils do lower triglycerides, and that may be part of their benefit, which is why I grouped the Reduce It trial with this. I would say that the science behind PPAR alpha agonism as a way of reducing inflammation and perhaps mitigating atheroma goes back a long way. As you see, this is a 20-year-old paper from my lab that is showing beneficial effects at the level of endothelial function. So I'd like to finish my talk by this basket of residual inflammatory risk. I think that this audience has heard me many, many times discuss how from the beginning, the alpha, through to the end, the omega, that inflammation drives atherosclerosis and its complications. This is a very old article from 2002. Here's the Brazilian version. Corações ardentes, inflamações são o grande vilão dos ataques cardíacos. And for those from Spanish-speaking countries, here's the Spanish translation as well. Okay? Now, what's causing this inflammation? I don't have time to go into it. I'd love to talk about clonal hematopoiesis, which I spoke about at the analog of this meeting in London earlier this year, but I direct you to this article where I'm talking about the non-traditional risk factors that may drive arterial inflammation. But the challenge is to go beyond what I knew in 2002, which was based on test tubes and experimental animals, and try and close that gap, try to cross the valley of death of translation, and bring home the concept that an anti-inflammatory therapy could provide clinical benefit by using the tool that we heard about in Dr. Pfeffer's early talk, the large-scale randomized clinical trial. So this is a driving goal of our research groups at the Brigham and Women's Hospital, and we want to tell whether anti-inflammatory interventions can actually improve cardiovascular outcomes in humans. For a survey of the whole field, this is a recent review that I wrote with one of our junior colleagues who is absolutely superb clinician and investigator, Brendan Everett. So I refer you to this, and I'll come back to this at the end of this talk. Now, let's first of all talk about lifestyle, because lifestyle should be the foundation of all cardiovascular prevention in heart failure, in hypertension, and in atherosclerosis. The problem is that I don't think we'll ever have randomized clinical trial data to support lifestyle interventions. I'm not going to go into look ahead. I'm not going to go into Predimed and the flaws and problems and disappointments with those studies. So let's stipulate that we'll never have a rigorous evidence base. So how do we move forward as clinicians? I think that we need to make Pascal's wager about lifestyle. So you probably know Blaise Pascal. I'm very proud that I got into arteriosclerosis a reference to Pascal's pensée, because Pascal said, well, look, if there's a God and I believe in him, I can win big. If there's a God and I don't believe in him, I can lose big. So I'm going to bet that God exists. So my argument is to make a Pascal's wager for lifestyle, that in the absence of real rigorous data, if we take the benefits of lifestyle on faith, the downside is minimal, but the benefits could be considerable. So that's my personal take on lifestyle. But what do we do about pharmacology? So we all were very excited by the low-dose colchicine study, which showed in a non-blinded kind of study design that there was a striking reduction in secondary prevention with low-dose colchicine, which we now all use in our practices for pericarditis. There are 4 randomized clinical trials, some of them sizable, very well designed, conducted by great groups. This is Colcott. This is the Lodoco 2, fully enrolled. We're going to have an answer about whether colchicine at low doses can improve cardiovascular outcomes, and some of the effects, maybe most of the effects of colchicine may be as an anti-inflammatory. There's a disease-modifying therapy which has revolutionized the treatment of rheumatoid arthritis, a paradigmatic inflammatory disease, low-dose weekly methotrexate. And there's also anti-cytokine therapy, which has been used in rheumatology, dermatology, and gastroenterology. So my colleague, Dr. Ritker, had the inspiration to translate those rheumatologic victories to our cardiovascular patients, and he waged battle with the funding authorities in the US and finally wrung out of them support for a study, a superb study, unbelievably well conducted, the cardiovascular inflammation reduction trial, which tested whether or not the same regimen which has transformed the lives of many of our rheumatoid patients could benefit our cardiovascular patients. And I think you all know that the study, superbly conducted, was a null and was halted early for futility. But we still have hopes that an anti-inflammatory intervention could actually provide clinical benefit. And I'm going to just give you one example, and that is neutralizing interleukin-1, which you can surmise from its name is a primordial pro-inflammatory cytokine. The basis of the trial, the CANTOS trial, is described in this fairly recent article, which really summarizes over 3 decades of work in my own personal research, which supports interleukin-1 beta as a target for atherosclerosis therapy. Here from 1986, you can see I hypothesized a role for interleukin-1 in atherosclerosis. And I'm not going to go through what many of you have heard from me before, that there's 2 series of amplification loops for IL-1 that can alter the thrombotic balance and fibrinolytic balance in a way that would promote clotting and decrease fibrinolysis. We know that the activation of interleukin-1 depends on a converting enzyme that is responsive to many disease-relevant stimuli. So I just refer you to this article and many others by other great scientists that support interleukin-1, and particularly interleukin-1 beta, as a target. So Dr. Ritker and I went to Basel, and we were able to convince the leadership of Novartis to go down the road of a large-scale clinical trial to actually test whether a monoclonal antibody that neutralizes interleukin-1 beta could improve cardiovascular outcomes. This is the design of the CANTOS trial. I point out that we selected for people with residual inflammation despite being on a superb menu of standard of care therapies. And we knew this was going to be controversial, so we powered the study for hard cardiovascular endpoints. As opposed to the statin trials, we didn't have any decrease in atherogenic lipoproteins. But we saw a striking and dose-dependent anti-inflammatory effect as gauged by measurement of high-sensitivity C-reactive protein. And I think, as you know, we met our primary endpoint and saw a 15% reduction in the primary endpoint on top of superbly treated patients with high-dose, highly effective statins. And this is, again, just the hard MACE endpoint, the primary endpoint. If we look at the people who on trial responded to the intervention by a greater than 50% reduction, greater than median reduction in CRP, we saw an over 30% reduction in cardiovascular mortality and the holy grail of all clinical trials, all-cause mortality. Of course, these on-trial analyses are subject to many confounders, and that's why Robert Glynn, our study statistician, did no less than 7 sensitivity analyses in the Lancet paper that reported this result. There was no way that we could make this effect go away. We reported this in the New England Journal in the end of 2017 when Paul presented it at the European Heart meeting. I just want to point out that, as this is a recurring theme, is that Brazil outperforms in its contribution to these large-scale clinical trials. You know, Brazil was a top enroller in Jupiter, our previous trial with rosuvastatin, and our 2 country leads are right here in the room, Professor Fonseca and Professor Nicolau. So thank you, Brazil, for all your contributions to our clinical trials. You have, and the sites that are probably represented by people in this room, have helped to move the science forward to help our patients. Now, why was CANTOS positive and CERT negative, the methotrexate trial? Well, if we look at the biomarkers, there was an alignment of anti-inflammatory efficacy with the anti-IL-1 beta intervention, but not so with the low-dose methotrexate. We can discuss that further, maybe over coffee. So CANTOS was a wonderful science experiment that justified 3 decades of my own personal research by testing the inflammatory hypothesis in atherosclerosis, but it also opened the door to a new basket of therapies. And I would say we've done many sub-analyses of CANTOS, but Brendan Everett, our brilliant younger collaborator, presented the heart failure data. And as John was stacking up the neurohumoral blockade, I'm thinking of the patients that I'm going to see next week, where the blood pressure is going to be 82, and the creatinine is going to be rising as we diurese them and as we stack on neurohumoral blockade. And what Brendan showed is that orthogonal to neurohumoral blockade and diuresis, anti-inflammatories may provide some clinical benefit in a targeted way in heart failure as well. So where are we? Have we reached the limits? Absolutely not. I think of Winston Churchill when the tide turned in the Second World War. Now, this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. And indeed, we have to go farther than we did in CANTOS. We paid a price for IL-1 beta inhibition because there was a very small but statistically significant increase in fatal infections. I think we can mitigate that with what we learned from the 6,000 odd people that were treated. But we still are just at the beginning of anti-inflammatory therapy. Of course, these patients felt really good. They had an over 50% reduction in their gout. But here's, again, an illustration of the principle that was enunciated by Mark Pfeffer and that was reinforced in subsequent talks. You gotta do the large-scale trials. Because everything works in preclinical studies. Here's a bunch of anti-inflammatory interventions that have been attempted. The pilot clinical studies are all promising. You know, we get really excited about the endpoint biomarker or surrogate endpoints, but we get disappointed when we do the outcome trial. Perhaps the omega-3 fatty acids, part of their benefit shown in reduce it may be anti-inflammatory, and we have IL-1 beta, and we will get an answer about colchicine in the next few years. So where are we going? How do we move forward to push the limits? Well, my own group is looking experimentally and trying to get clinical trials going at other parts of this pathway that I talked about that leads to the acute phase response. The inflammasome, IL-1 beta, IL-6, IL-18, etc. So stay tuned. I want to come back here the next time that we meet at the limits and try to push the envelope, push the limits of anti-inflammatory therapy. I'd like to thank my colleagues, both the team of Dr. Ritker, with whom I have a almost 20-year association in trying to close that translational gap, and the people in my lab who are hard at work doing the basic science studies to provide the foundation for the clinical advances. Here's my lab party about a year ago. We will have another party, I hope this August, if the weather permits. My lab isn't really this big. A lot of these front row people are summer students who flock to my laboratory to have some fun with us during the summer. So thank you very much.